All righty. Well, why don't we go ahead and get started just in the interest of time. Thanks so much to everybody for joining us for our August 2nd, 2023 virtual tumor board for AHNS fellows. I'm Mike Moore from Indiana University. Really a big thanks and shout out to Trevor Hackman and Ryan Jackson from the Mucosal section for their work in organizing this fantastic session. So as you guys likely are aware, these are hour-long sessions, 3 cases, 20 minutes each, brief case presentations, and then we'll have a lot of questions fielded by the expert discussants. I'll be manning the chat box, so for the fellows wanting to add comments or questions, or the faculty, please add things in there and I'll try and bring them back to Trevor so we can present them to the group. So again, thanks so much for joining us. These sessions are all recorded and are then archived on the AHNS website for access in the future as well. Trevor, thanks again. I appreciate you organizing this.
Sure. Absolutely. Thanks for letting us take this on. And a huge thank you to our panelists and experts tonight who in the summer were able to flex and pivot on a short time schedule to make this happen. So we have 6 great panelists and 3 experts here to talk us through some challenges in oral cavity cancer. We'll start with Mia Yusuf Begovic, my former fellow. I should know how to say that. Mia is currently at Norton Health in Kentucky, and we also have Jeremiah Tracy from Tufts, who will be presenting as well, and then Caitlin McMullen from Moffitt, who are our 3 panelists presenting cases and the challenges of oral cavity cancer, and our esteemed experts, Cecilia Smallbach from Temple, Steve Kim from UPMC, and Rohan Walfakar from LSU. And so we'll get started here. We do record these sessions, so we know people watch them afterwards. Please enter things in the chat as you have comments or questions, but we will kick off with the first case presentation from Mia.
Okay, so like Dr. Allen said, my name is Mia. I am in Louisville, Kentucky, and I'm going to present a case of a early stage oral cavity squamous cell carcinoma, so we can discuss a little bit about different management options for that. Okay, so our patient today, she's an 86-year-old female. She has a past medical history of breast cancer that was treated about 10 years ago. So this is a semi-recent patient, so you can take the years to be accurate. She had a history of a DVT at that time, so she's on a blood thinner, hypertension, a little bit of a strange history of an idiopathic vocal cord paralysis that was diagnosed about 7 years ago. Saw an ENT at that time. They said it's idiopathic, discussed medialization, ultimately decided not to do anything. But she is coming to see you today because she has a new ventral tongue lesion. So this has been present for about 3 months. Initially, it was thought to be due to irritation. Got a new lower partial denture. Her dentist said it's probably nothing to worry about. Let's watch it. Persisted, so she got sent to an oral surgeon who did a biopsy of it. This confirmed squamous cell carcinoma, so she got sent to us. The lesion is causing her a little bit of mild discomfort, but she's eating and drinking well. She hasn't had any significant weight loss. She's a never smoker, no history of alcohol use. She is 86 years old, but she lives independently and is relatively functional. So this is the biopsy report that comes with her from the oral surgeons. They called it about a 1.5 centimeter lesion, erythematous. They biopsied it, and on the path report, it comes back as showing you at approximately 3.6 millimeter depth of invasion. On this is how they marked it. The next slide. And then on your physical exam, you see a very pleasant, alert, elderly female. She does have breathodysphonia that's consistent with her previous vocal cord paralysis. On exam, it's a little bit bigger than they describe it, probably about a 2.5 centimeter ventral tongue lesion, predominantly right-sided, but really does encroach upon the midline, and not quite to the other side, but close enough that you are thinking that it does involve really the center of the tongue. It's got some mild induration, a little bit of tenderness when you feel it. She's got moderate dentition. She's got that lower partial that's in place. Clinically, you don't appreciate any palpable adenopathy. And then your flexible laryngoscopy does confirm that she has that left-sided vocal cord paralysis. So these are the scans that we obtain on this patient. A lot of dental artifact, so difficult to see into the oral cavity. But don't know if anyone wants to comment on. And the read that she comes to you with is can't really see the tumor and there's no appreciable adenopathy on the scan.
Is it possible to like scroll through the oral cavity a little bit slower?
I might. Can you toggle on the bar and see if we can hold the bar down?
Checking.
No.
No. I think I can.
That's fine, no worries.
Okay.
Next time?
Mm-hmm.
Oh, my apologies.
Okay. So topic of discussion, what would be treatment recommendations from everyone on this with regard to her primary tumor site, the neck management, affecting any reconstruction? And then as we mentioned, this patient's an 86-year-old lady. So does that impact how you are treating this malignancy?
So I guess we can start with on this list. What do the experts think about how would you approach neck management and counseling the patient about the neck?
Okay, I'm to speak up first.
Go
Yeah,
for it.
so, you know, I would say if this was a young patient, pretty healthy, you know, I would first think about a neck dissection with regard to management of her neck. But there are two factors that are in consideration here. The fact that her left true vocal fold is paralyzed, and the fact that she's 86 years old, with some drive to get her off the table as soon as possible. You know, if you are to employ a neck dissection as a management strategy for her neck, it sounds like it'll have to be a bilateral neck dissection. You know, if she was healthy, and getting her off the table is not a consideration since the tumor does go up to the midline. But, you know, in doing so, you know, she's got a left true vocal fold paralysis. And so, you know, if you injure the vagus on the right side, then it's going to be a big problem with bilateral vocal fold paralysis. And doing bilateral neck dissection in addition to the primary tumor, it's going to take a good 5-6 hour surgery to get the surgery done. So that may not be something for an 86-year-old patient. So either you can go with just unilateral neck dissection, or the other option would be, I think, sentinel lymph node biopsy may not be a bad option for this patient.
That's great comments. I would look at it slightly differently. It seems like from the history that this is a pretty, you know, spirited 85-year-old who is, you know, would seem to me would want to have everything done to be able to, sorry about that, to be able to get treated. I think if we, I would consider doing basically treating them as though they were like any other patient, you know, hemiglossectomy with a neck dissection. I think the likelihood of injuring the vagus in a selective neck dissection is extremely low. And so, you know, I think, you know, this is one of those cases where, you know, you would want to take ownership of, you know, making sure that the fellow or yourself are doing the neck dissection and get through the case. You can be, you know, temperate in how much you dissect and do, you know, a selective right-sided 1 through 4 neck dissection, but then you don't have to be as aggressive on the opposite side if at all it's required. But given the fact that this is a pretty thick tumor, I would consider just a one-sided neck dissection, and then post-operative radiation may be a consideration in this case, which could cover the opposite neck. That's how I would think about it. And as far as the vocal cord paralysis, I think that's definitely a consideration, and I would have a conversation about that with the patient. But you know, I think this patient has an opportunity to get a full-fledged, you know, comprehensive treatment. So I would try to go for that.
Yeah, I agree with both comments. I think it all comes down to just the overall performance status of the patient. The challenging part of this case is that the depth, you actually have a depth of invasion up front on biopsy. That's usually, or a lot of times, not the case. And certainly with it approaching, 4 millimeters, we do worry about occult nodal metastasis. If she had come to me, just to give another scenario, and that we didn't know for sure the depth of invasion and it felt pretty thin, this is the type of patient that I actually stage and would resect the primary, figure out what is her real depth of invasion, and then base my next steps off of that. I do think if you're going to do a neck dissection, you just need to commit to it. And I thought that was just nicely described.
Thank you all. Would any of you consider a sentinel lymph node mapping on this patient? And if so, great, why? If not, why not?
I brought up the sentinel lymph node biopsy, so I guess I should comment on that. Again, a lot of it depends on the patient's overall health status. And so I do agree that if she is a spry, healthy 86-year-old patient, a bilateral neck dissection would be the first choice. But, let's say she was not healthy and there's some concern about putting her through a major resection. I think in that case situation, I think a sentinel lymph node biopsy is not an unreasonable option for her.
If we had Dr. Smallbach's presentation where they came, there's no depth of invasion, would you consider, when you do your staging, doing a sentinel node at that time, or would you just wait for depth of invasion?
One is I don't do as many sentinel lymph node biopsies, but irrespective, I think I would probably just do a primary resection. I think there's a lot of value you get when you actually, resect the tumor and feel the tumor three-dimensionally. You kind of get a sense of how deep it is also. And I think that's extremely valuable in making your decisions about the neck in an 85, 86-year-old. I think if I was not sure of the depth, I would definitely consider primary resection and then staging the neck.
I will add, just to help guide, my suspicion was that the depth of invasion was slightly more than what the pathology report was telling me. So I didn't quite fully agree with that DOI.
In the physical examination, was it apparent on bimanual palpation whether this was a thicker tumor versus more superficial? Was there any?
I thought the depth of invasion would be more than 4. I wasn't expecting it to be like centimeters big, but more than 4 for sure.
And that gets into the next challenge of the patient that gets sent in, biopsy done. How much of that thickening at the time of your evaluation is a reaction to the biopsy? How much of it is actually the tumor? And what if they take the whole thing out and you can't see anything? Those are all challenges we face. How about management of the mucosal margins on the primary site? How much of a margin are you shooting for? Are you taking margins off the specimen or off the patient? And then what are you doing to close?
I'm happy to start with that. So, I'm going to try and achieve a 1 centimeter margin. That includes both peripheral, but I think where we really oftentimes will lose is with the deep margin. So I'm very cognizant of that. I try and walk the specimen up to pathology and mark it with them and point out which areas I'm most concerned about. And then at times, if I'm unsure about that deep margin, I don't mind taking a second deep margin from the patient himself or herself, but whenever possible, again, I'm sitting with the pathologist getting the margins off of the main specimen. So that's how I address that. And then did you ask about reconstruction too there, Trevor?
Yeah, because it's a 2.5 centimeter lesion. So if you're taking a centimeter margin throughout, that becomes a 4.5 centimeter defect in one direction. So what are we doing for recon?
Yeah, so it all to me depends on if this extends by the time you get your surgical margin, if it extends onto the floor of mouth. So I like to teach my my residents that, you really should treat the floor of mouth and the oral tongue as two different subunits, much like we have the subunits of the nose. And so I may, if it's small, let the floor of mouth granulate in, assuming we always have to think about the submandibular gland duct. And I'll close, for example, the tongue primarily. Without seeing a picture, it's a little bit challenging for me to know, and I'll be curious, Mia, to learn from you about what you did. The other thing that I've come to appreciate over the years is if I am primarily closing oral tongue, I actually try to do so in an anterior to posterior direction as opposed to dorsal ventral, because otherwise you wind up tethering the tongue. And really what you want to ensure that they have is excellent mobility. That kind of goes back to my original point of treating the floor of mouth and oral tongue as two different subunits. At times, I will say I have used Alloderm, though in my hands, I feel like it's more of a biologic dressing, giving them some, maybe a little bit of relief from pain. So those are just some pearls to throw out.
Trevor, you had asked about where to take the frozen section from, specimen or the defect. So I think the latest studies, including the studies here out of UPMC, have shown that the frozen should be taken from the specimen, not from the patient defect, and that's more predictive of the true margin status. So that would be my answer to that. With regard to the reconstruction, I do agree with all of Cecilia's comments. The thing that you got to watch out for here is they don't want tethering of that tongue onto the floor of mouth as she heals. And so depending on the size of the defect, sometimes skin graft is adequate. The other consideration is that when you remove the ventral surface tumor, the dorsal surface that is left is very thin, it's very devascularized. And so that's going to die if you leave it like that. So in a patient like that, I would just sort of chop off the anterior tongue, do anterior partial glossectomy. But in those kind of situations, often you doom them to a free flap reconstruction. So again, it depends on the defect size, but the thing that you got to be cognizant of is try to minimize the tethering by utilizing skin graft or free flap or whatever is necessary.
I'm happy to comment as well. I think I agree with all the comments. In my particular practice, I tend to take the specimens of the remnant tongue, and I sometimes, if I'm really close on something and I feel like I need to I'm going to compromise some function, I won't hesitate to mix it up and take a specimen, a particular margin of the tumor, if I'm going to save function in a particular case. But in general, I do take circumferential margins of the residual tongue. I was pleasantly surprised to hear that primary closure is a consideration, because I think we constantly think about free flaps. But even with a hemigloss, my time at Tata Hospital in my fellowship in India, we did so many hemiglossectomies and just rotated the tip of the tongue to close the defect. And it's not always pretty, but it's very functional. So in an 85-year-old, that could be a consideration, and you can get pretty good function with just a primary closure of that tongue.
Just to throw it out there on the slide here, I've listed on the reconstruction, pedicle flap is listed here as a possible option. So, would anyone here ever consider submental island flap to reconstruct a ventral tongue defect like this?
I've done it, so I will say sure. I will consider it. I'll use a submental island flap for a lot of defects, including the ventral tongue. There's no risk to transferring lymph nodes into the defect. You can remove the lymph nodes from the flap safely, and I think it's a pretty good flap. But I think going back to Cecilia's point, and it should be underscored for the trainees, the floor of mouth is critical. You have to create a trampoline between the tongue and the mandible. Without doing that, you tether your tongue to your mandible, you lose articulation, you lose swallowing. So the floor of mouth is critical, even more critical than the tongue, per what Dr. Kim and Dr. Walker are also saying. You can take half a tongue, but if you take any of the floor of mouth, it matters a lot. Well, why don't we keep moving forward so we can get through this case to the next ones as well. So next slide.
So I took the aggressive route. This
And
lady got
I'll
her
point
punched.
out Don Weed in the chat put down a forearm flap is a good choice for floor of mouth if the patient is healthy and she drives the decision making. So there you go. Don Weed is on your side.
So she actually did really, we did a partial glossectomy on her. I did address bilateral necks. To me, it didn't seem like it added a whole lot if we were doing a neck dissection on one side. I was worried enough about it encroaching the opposite side that I felt like it needed to be addressed. And then we actually counseled her on, let's see how the defect looks. And then based on that, we'll talk about if it's something we can leave open, something we can close, do a form. After doing the resection, my concern was the tethering that everybody else has kind of talked about, it just being in the ventral tongue and extending to the floor of mouth. And so my partner did a beautiful radial farm free flap on it. And I did not list it in here. One of the other things we did do during her hospitalization, we medialized her vocal cord. We knew that this was going to give her enough swallowing dysfunction just from having new anatomy in her mouth that we wanted to try to do anything we could to try to improve her swallow function. So did go ahead and do that. And then the next slide has her pathology.
Mia, I was just curious, did you do the vocal cord medialization before the big resection or after the big resection? When did you
No,
do it?
so after, had kind of honestly intended to do it at the same time, but because I wasn't sure what the reconstruction was going to look like, didn't do it up front. And then when we did the free flap, decided to delay it. And actually, we waited for the pathology report to come back. We had some like questions about dentition. And so when she got her teeth, well, I don't, spoiler alert, but when she ended up going back for something else, we did the injection at the same time, probably about 6 days later, I think something like 6-7 days after the flap, did the injection.
Thanks.
So her pathology came back as a 3 centimeter squamous cell carcinoma. Her DOI was 7.5 millimeters on the permanent pathology. Had negative margins, 4 millimeters was the closest margin, and then did have, I believe it had positive LVI. I'm trying to find it. Yes, no, positive PNI on it. She had 3 positive lymph nodes bilaterally. Each 1B had a positive lymph node, and then on the right side, the ipsilateral side to the tumor, a level 3 node was positive. All of them were sub-centimeter. 0.9 was the largest one. Then kind of came the second question. So we did this surgery on this 86-year-old lady. So adjuvant therapy recommendations and what to do with her pathology.
That's like a really tough question because it really depends upon how did the patient do with the whole surgery. Like, I mean, did she do well? I mean,
She did really well. Yeah, so she did well. She was in the hospital for about a week. We sent her to rehab for about a week afterwards. By the time she left rehab, was eating by mouth. We did an anticipate. She got a feeding tube placed at the same time, so it was kind of combining, doing some nutrition through her G tube, doing some nutrition by mouth. Yeah, it's actually tolerated it really well.
She didn't have did she have a trach that was removed later or no trach?
No, she was never trached.
Yeah, I think I would lean towards post-operative radiation, both to the primary side, more aggressively to the ipsilateral neck, and talk to the radiation oncologist about maybe, especially the contralateral neck didn't have any positive nodes, right?
It did. It had, each 1B had a positive node, and then the ipsilateral had a lateral neck.
Yeah, then I would give them, the radiation that they could tolerate, but I would obviously not recommend any chemotherapy for this patient.
No, I agree with Rohan. I mean, if the patient did okay after surgery, it sounds like she did, which then indicates that she's a relatively healthy person. So I think that in this case, she should definitely get at least adjuvant radiation therapy. And I would advocate radiating both the primary site and both sides of her neck.
All right, that was a great first case, so we can keep on time. We'll go to our next case. I think it sounds like adjuvant radiation therapy.
That's what we did. She did great. She's finishing now.
All right, so we're now going to jump to Jeremiah Tracy, who has the next case for us. I think you're muted, Jeremiah.
Let's try that again.
There you go.
Thanks to the organizers for having me present, and thanks, Dr. Yusuf Begovic. That first case was very interesting. I like there are a lot of margin calls there. The case I have, maybe more straightforward. This is a 82-year-old who first presented with pain of what he thought were his mandibular teeth, possibly the mandible. His dentist pulled 2 of his right mandibular molars. Unfortunately, the pain persisted and his tooth sockets had not yet healed 6 months later. He was seen by an oral surgeon who did a biopsy. And so when he got to me, he did have a pathologic diagnosis of squamous cell carcinoma. He was quite healthy for an 82-year-old. He had a history of tobacco use, but not for, I think, almost 20 years. And really, metoprolol and metoprolol and simvastatin were his only medications. He had this about 1 to 2 centimeter lesion involving the right mandibular alveolus, kind of visible submucosal extension. It seemed to be fixed to the mandible, and there were no palpable lymph nodes. He had a PET CT scan at the time of my evaluation showing FDG uptake at the primary site, but no concern for nodal disease or metastatic disease. And I actually got a CT scan of the neck, soft tissue neck with contrast as part of preoperative planning, which we read as demonstrating cortical bone involvement. So I guess this would be my first pause. Any further workup to complete staging and initial management recommendations?
So he has a biopsy and a PET CT scan?
That's right.
Okay. So with regard to the evaluation of the tumor, to me, that's pretty adequate.
And what was the time frame between the biopsy and the dental extraction?
So the dental extraction was 6 months prior. That's where the delay occurred. But between the biopsy and him seeing me was quite quick, a few weeks.
Yeah, and the PET CT scan is pretty recent too, right? That's not that old.
Yes, that was all ordered by the oral surgeon who identified the cancer.
Okay.
And then I did have also a CT soft tissue neck with contrast.
Mm-hmm.
So we've all unfortunately seen these patients. First of all, you guys can't operate anybody under the age of 80 apparently, but we've all seen these patients who come in, right, with loose dentition or stuff around the tooth. They pull the tooth and you've got cancer around the socket. So what's the on Dr. Tracy's slide? Are we doing a marginal mandibulectomy? Are you doing a segmental? What are you doing? And what are you doing with the neck?
In this case, I'm definitely doing a segmental mandibulectomy. The one thing is it's pretty straightforward with respect to the bony erosion. I also, to your point, Trevor, just to again underscore for the fellows, when there is a tooth extracted, presumably in the bed of where cancer was, you almost have to assume that it's in the medullary space, meaning you can't afford to leave cancer behind there. And that's why I would err towards a segmental over a marginal. But again, very straightforward with these nice images. And then I would do certainly do a neck dissection as well on that side. It looks like from your photo that this is right-sided, and that even with a good 1 centimeter margin, it's still right-sided. Is that fair to say? There was no midline involvement?
That's right. It was very isolated to the mandible and the gingiva. There was really pretty minimal to no, floor of mouth or buccal involvement.
Yeah, I agree with all the comments. I'd just like to say that on the scans, like whenever you look assessing mandibular tumors, look for paramandibular spread, look for the sublingual space, and whether that is asymmetric as compared to the other side. Look at the symmetry of the midline tongue musculature. All of those things are important to decide whether this is truly sort of a lateralized tumor or has some medial component to it. I agree that in this case it looks pretty obvious that the patient needs a segmental. There's too much of bony involvement to consider anything else.
Yeah, I agree. Segmental is a standard of care in this situation. But just to make the discussion a little bit more interesting, what if a patient said, "Hey doc, for whatever reason, he loves his mandible and he does not want to go through a segmental mandibulectomy. He says, there's no way I'm going to go through a segmental mandibulectomy. Explain to the patient that even if you do a marginal, the soft tissue defect will be large enough that he's going to need a flap to cover the soft tissue defect anyway. But for whatever reason, he does not want a fibula free flap in a segmental. Then well, how would you then, how would you proceed? Would you do a marginal?
That's a really great sort of scenario, which I hope I never have to encounter. But if it did come down to that, then I have to be true to what I think is going to work. And in that situation, it would be an inadequate surgery. It wouldn't even be palliative, because you're going to kind of cut through tumor for the most part and sort of leave the patient in a greater disadvantage. And I would just have them consider a non-surgical treatment option at that point, even though it's probably not the right option for them.
Yeah. Dr. Tracy, can you go back to the CT scan that you had shown previously? So on that axial, on that coronal cut, you can see the degree of bone invasion into the mandible there. Now, I had patients like this, handful of patients in my career who, for whatever reason, they refuse a segmental. And their tumor was eroding the mandible from the occlusal surface like we have here. So I've relented on these patients, and I have done marginal on these people, but doing the marginal, but taking a very significant portion of the mandible, leaving a fairly thin rim along the inferior aspect and plating that to bolster it. And by doing that, on 3 of these patients who had refused a segmental, I was able to get a negative margin on the bone, and with adjuvant therapy, they done okay. But so on some of those patients, I have taken that approach. But I do agree with everyone that the standard of care is segmental mandibulectomy.
Even those, sorry,
I'll put it one more step forward. And that's why I asked Jeremiah, the dental extraction was 6 months prior. So are you sure that this amount of bone loss is due to the cancer, or could it be from the dental extraction and from 6 months ago? And then just to be devil's advocate, and looks like there's a pretty big distance between that and where the nerve is. And if the patient doesn't have mental numbness, they're not involved in the marrow space. I still think a segmental is what most of us would do. But if you do a marginal, Steve, do you do a marginal and then wait for final path and then go back and do a segmental neck if you need to, or are you doing a neck when you're doing the marginal, if you're doing a marginal and then maybe like?
So if I'm doing a marginal on this patient, I'm doing the neck at the same time. The main reason is that to put the plate on, it's easier if you make a neck incision and raise the flap over the mandible. And so if patients have a neck incision, the neck's gonna be opened up, I'll do the neck dissection at that same time.
Yeah. I mean, it is true that like sometimes you can get away with marginal mandibulectomies. This particular case, I think it would be really difficult to get away with one of those. But there are certainly something to consider. And I think if you have a proper discussion with the patient preoperatively and look at all your options and say that I'm going to consider doing a marginal, but if things don't look, you can always kind of have a backup of a segmental resection, and sometimes you can get away with it.
Yeah,
sure.
I think there's a difference between mild cortical erosion and irregularity versus involvement in the medullary space. And this is actually, and Jeremiah, I don't know if you were hinting at this earlier, most neuroradiologists would actually prefer an MRI if we are really questioning bony involvement into that medullary space, because they can look at the enhancement better. So that's just one thing to think about. But I will still stick to my segmental.
I would agree. That's a great point,
Yeah.
Cecilia. And the last thing I put on there is if you're going to do a segmental for the trainees, you're going to take their mental nerve. So when you're doing the neck, you have to be very careful you don't take their marge, because if you give them a numb lip and a weak lip, you affect their oral competence, which could be a big factor in the quality of life of anybody, but especially this 82-year-old. So you have to be very careful. Once you've taken their sensation, don't also take their power. Go ahead, Jeremiah.
So this patient did indeed have a segmental mandibulectomy, an ipsilateral selective 1-4 neck dissection, and was reconstructed with a fibula. The surgical he did well perioperatively. The surgical pathology actually showed a 1.4 centimeter tumor 7 millimeter depth of invasion with no bone involvement. And this was, confirmed with the pathologist pretty extensively. LVI, PNI negative margins, no lymph nodes. So final pathologic staging was T2, N0, M0. And I guess, my question for concern is, I guess what I'm hinting at is do we have any remorse for doing a segmental on this patient with the T2 disease, and any pearls that you have for identifying bone involvement preoperatively? And I guess final would be any role for adjuvant treatment in this case.
Yeah, first of all, no remorse at all. You done the surgery that you thought was indicated based on the preoperative information. What I would tell the patient is, emphasize a positive. Listen, your cancer did not invade the bone. Your cancer has been taken care of. You don't need adjuvant treatment. You're good. So I would reinforce a positive, but the surgery, if this was my patient and I'd done the segmental, then you've done the surgery that you thought were indicated based on the preoperative scan. So there's no remorse on that. In terms of identifying bone involvement, obviously CT scan is what you start out with. And as Cecilia said, if you have any concern, MRI would be your second line study. But I have patients who on CT scan who had no evidence of bone invasion, and I do a marginal, and the path comes back with T4 cancer with positive bone margin. So that has happened to me as well. But I would say relying on the CT scan, using the MRI as necessary, and your clinical assessment is what you have to rely upon to assess for bone invasion.
I agree, Steve. And I think the onus is really on us as surgeons preoperatively to say, please realize there's a chance we're going to go in. And despite, thinking we need to do this segmental, we may not find bony erosion. And it's easy to look back and say, gee, I wish I didn't, but it's A, the only way to know. And B, if that happens, we're going to celebrate because you don't need radiation. And that's just a great sign. It's early stage. So I think being transparent up front, explaining the why, and then finding the positive, as Steve was saying it, and that's easier to do up front before you go to surgery, and then you can just reinforce it on the back end.
I think sometimes also, and again, I wouldn't say that this trumps getting a CT, but sometimes when patients come with OPGs or orthopentomograms, you get some really cool bone architecture and perspective that you don't get with a CT. And sometimes it's worth looking at that also. But I again, there would be no doubt in my mind that I would change my management based on the scans that you showed us. So yeah, and no remorse, like Dr. Kim said, you did the right operation for the tumor.
Thank you, Jeremiah. That is a great case, and it is a challenging case. This one's seemed like it was more straightforward because of bone erosion. And that was my question to you, Steve, is that sometimes I'll do a marginal, but I don't do the neck at the time of the marginal. And the main reason I don't is because if the bone is positive, then I haven't violated my neck and I can go back in and do my segmental and free flap. Mm-hmm. But what I would say in this case too is sometimes, and you might speak to this, Steve, sometimes the soft tissue margins are easier to get widely negative when you do a segmental. When you're doing a marginal, sometimes you don't get as good of, because you're approaching it in a different way. Mm-hmm. Maybe your soft tissue margins on your path report, Dr. Tracy, wouldn't have been as widely negative if you had done a marginal. You may not have taken the same cuff of tissue because you're trying to kind of get the saw in there. And so doing the segmental may also not only take care of the bone, but expand a little bit how you manage the soft tissue around it too.
Great.
All right, Caitlin.
Hey, before we move on, did you radiate this patient or observe?
No, and so I appreciate everyone's input, and that's exactly what I think about it. I kind of think about it as, the classic teaching for appendicitis, right? In general surgery, like they should remove a certain percentage of normal appendices to make sure they're not leaving appendicitis behind and having ruptures, right? And in this patient, it worked out great since he did have no nodes, otherwise no high-risk features. He had no radiation. He's 2 years out. He's getting implants placed shortly, so he's happy.
I think the other important point, I realize we're a little bit almost out of time, but he's fully dentate. So by doing that fibula, you now gave the opportunity to do dental restoration, whereas with a marginal mandibulectomy, I think for this particular case, that would have been nearly impossible.
Mhm. Point. Very good point.
Yeah, there's pretty, I mean, having dental is not something which is commonly, like, you don't commonly think about it as a part that at least we do as head neck ablative surgeons. But a lot of the OMFS literature talks about like actually having the implants in the fibula at the time of reconstruction, and that has several advantages of not exposing that irradiated fibula then to implants later on. So that's just something to consider.
All right. Thank you, Jeremiah. All right, Caitlin.
Okay. Sort of a less fun case. More depressing. Okay. So this was actually a patient I saw recently, so I don't have a long-term follow-up for him, but 56 years old, excuse me. But he does have some mild to moderate dementia. He's not entirely independent, but he does kind of understand what's going on. He can answer questions appropriately. He's on Namenda for that. He has a history of cirrhosis in the past, but his LFTs are currently normal. He's not actively drinking, but he was a former heavy drinker and a former heavy smoker. When I saw him, there had been some delays in his care, and he had lost a significant amount of weight. His BMI was 17. He had temporal wasting. He looked quite frail and pretty severe trismus. It was a limited exam. This is pretty much all I could see, but if I really got in there, I could tell that the tumor was creeping up the retromolar trigone, was extended to the posterior buccal mucosa, and was along the posterior maxilla as well, and then into the lateral pharynx. And you can see in the midline there, there's extension under the gingiva, almost to the midline. So he had that was it. That was what I saw when I first saw him. He had nothing else available besides a biopsy showing squamous cell carcinoma. What would our experts do for their next steps in management?
I would get some imaging done first. Obviously, a full head neck examination of the clinic, scope the patient, just understand the airway, and then get some imaging before, doing anything intraoperatively. Patient will probably require a proper EUA, but that's, we run the risk of requiring a trach at that time. So I'll get the imaging done first. Thanks. And my imaging of choice would be a CT scan, 1 millimeter cuts with and without contrast. And of course, PET scan also at the same time.
Anything else?
I assume that you don't have a tissue diagnosis yet, correct?
No, we do. It was a squamous cell
Okay.
carcinoma. That's the
Okay.
only thing he came in with.
Okay.
All right. Shall I carry on?
Well, I was going to say there are a lot of consultants that you need beyond.
Oh yeah, go for it. Go for it.
My biggest concern is that BMI is 17. I imagine this patient came in a wheelchair and probably never even made it into your exam chair. And you mentioned temporal wasting. And so I just worry about this individual being able to make it through any treatment. A lot of times with the dementia, they don't have a whole lot of social support. So getting social work involved, depending on how frail they are, I'd want to know more about their swallowing. So certainly would do a formal consult to SLP from that aspect as well. And there it looks like there was pretty poor dentition there. So eventually getting a dental evaluation, which is going to be exceedingly hard with that trismus. But from a practical standpoint for the fellows, like you have to prioritize of like, where do you start? Because those are a lot of appointments and really long days for someone who's probably exceedingly debilitated.
Is there anyone else based on the trismus and the I think, was there mental numbness or anything? Was there any signs of V3
Yeah, he
numbness?
did have some lip numbness, but it was kind of a little bit hard to elucidate from him, but it did appear he had some decreased sensation on the left lip.
Would that prompt any additional or different imaging from any of the faculty besides the CT and the PET?
Yeah, I mean, if you're worried about perineal involvement of a major name, cranial nerve MRI should be done to make sure there's no intracranial extension. But I have another question about this patient. What is his social situation? Is he living at home with family, by himself? Is he institutionalized? What is his situation?
Yeah, great question. Great points brought up about his social situation. So he actually has a very dedicated wife who married him when they met in high school. So they're longtime partners. He lives at home with her, but she works full time. And their insurance and stuff like that depends on her work schedule, and she has very limited time off. So it took a long time to get the stuff done that I wanted to get done.
Yeah, I totally agree with the idea that, like, you have to think about this patient holistically. I think the reason why I jumped to CT scans and PET scans and EUAs is because ultimately, like, the first thing I want to assess is resectability of this patient. However, whether that's even a possibility or not. Because if I know with the CT scan that this patient has extensive, soft tissue involvement and high infratemporal fossa involvement, then I'm going to activate, my thought process in a very different direction. But you're absolutely, this is an extremely challenging patient and requires a lot more sort of in-depth, considerations before you make any formal decisions.
Thank you, guys. So, when I saw my priority really was at the time his nutritional status and social work, just to get that stuff lined up. He wasn't going to be able to tolerate really any kind of treatment in his current condition. So G-tube was priority number one. His airway was actually fine. So he got his G-tube. He saw nutrition. Social work was working with them. We got his pain under better control. He was actually still actively smoking, so we worked on that too. And I ordered some imaging. I sent him, kind of shotgun, ordered all this stuff. I sent him for multi-D discussion with also radiation medical oncology. I like to establish with them early, even if I am going to think about going to surgery, our radiation oncologists do appreciate examining the patient prior to surgery so they can understand the lesion and margins, what they're going to do post-operatively. So I usually consult them early on, especially for advanced tumors where they're probably going to need adjuvant if we get to surgery. And then we brought the tissue over to Moffitt and we reviewed it and agreed it was a keratinizing squamous cell carcinoma, P16 negative. So I'll just go through some of his imaging. These are just some screenshots, but you can see extensive destruction of the mandible across midline, invading half the tongue, almost to the midline of the tongue as well. And extending on the posterior aspect up into the medial pterygoid there. The pterygoid plate wasn't quite clear. It looked okay. It wasn't quite eroded, but certainly masticator space involvement. You can see on the axial here the extent of the pharynx involvement, okay, and the hemitongue. And you can see anteriorly all the soft tissue. It wasn't quite invading skin, but you can see it's quite close. This is the PET scan. He did have a contralateral lymph node. So he had N2C disease in the neck. And you can just see how absolutely massive this is, extending in the posterior maxilla there as well. I looked at the nerve on the PET scan. Obviously, it's not the best modality, but honestly, I was not optimistic about surgery for him, and so I didn't want to put him through an MRI. But if I were really going to consider going to surgery, I probably would have ordered that. So this was his staging based on imaging, T4B, masticator space involvement, N2C M0. So what would our experts do next?
Yeah, no, I agree with that T4B designation. I think that this tumor is at that presentation unresectable. If you had a patient with this type of tumor and they really wanted you to do everything possible, including consideration of surgery, I think one option is neoadjuvant treatment, whether that be chemo or a combination of chemo and immunotherapy, and see how the patient's tumor responds. And in some cases, we have seen patients who do respond significantly, where we think that surgery does become feasible, not easy, but feasible. So that's an option. But otherwise, I would say most patients would recommend probably non-surgical, chemoradiotherapy for a tumor like this.
Yeah, I definitely would lean on our tumor board. It's interesting, Caitlin, from the dementia standpoint, like, was he able to participate in his decision making?
He was.
Okay.
He could answer questions appropriately. He understood what was going on, but in terms of his day-to-day, he's not driving the car. He's not, doing his bills.
Sure. So, I think that you have a couple of options. Any surgery in this case would be heroic. There would certainly be positive margins. I just want to reiterate, I thought you brought up a great point for the fellows, Caitlin, that, when you start seeing trismus, you think pterygoid invasion, and you need to think about the sphenopalatine, pterygopalatine fossa, and the MRI can be really helpful in evaluating that. Looking at a non-surgical option, I think one of the priorities, assuming they want to continue with treatment, is actually to get a feeding tube in and start getting him some better nutrition, so that you can look at some aspects with respect to systemic therapy and or radiation. And then I think you also need to be candid and talk about palliative treatment and hospice as well.
Yeah, no, I agree with that, Cecilia, for sure. This tumor, I think, is, unlikely to be curable, regardless of what we employ here. So I think that consideration of palliative treatment and hospice is a very important aspect of this patient's treatment plan.
Yeah, I totally agree. I just want to say that, from the fellow's perspective, that there are T4Bs and then there are T4Bs, so I think when we look at scans, everything looks sometimes unresectable, and you have to, rely on the scans, but sometimes an examination or an anesthesia is so important for you to be able to understand how those tissue dynamics work. And many of the times when you have really advanced looking tumors, you'll actually, once you do an EUA, you feel like you may be able to get around it. And again, it's a very tricky situation, right? Because if this patient was, say, 10 years younger and he was like absolutely with it and had like a young family, you would want to do everything that you want, that it possibly can for this patient. So every case is unique and presents its own sort of decision-making challenges. But, I often find that people at tumor conferences are very quick to make decisions based on just imaging, and so just make sure that don't hesitate to take the patient back and do a proper examination and anesthesia before we make any final calls.
And to bring up, that's a great point, Rohan. And to bring up from the chat, Don, we put in there to not forget this guy has some cirrhosis too, so he may not be the best wound healer. And even if you did a heroic surgery with a flap, it's going to be 2-3 months of recovery. And then what happens is that the cancer recurs literally at the margin of your resection 3 months afterwards. And so I think those are the cases I think that we all regret, the ones that we pushed and then basically just they were recovering, they recurred. And so the saying that I've given to patients and thankfully not very often is, there's worse things than dying. It's what I could do to you before you die. And I think that's the mentality I would take into this case. And even think about radiation therapy. If had a great response, I think that might also be toxic. So it may be palliative or palliative immuno alone.
Yeah, I agree. I agree. I mean, I see where Ron is coming from. We see these patients, of course, our gut reaction is we want to help them, with regard to the cancer. But on the other hand, sometimes helping them is guiding them away from surgery that is not going to help them. In fact, it's going to make things a lot worse for them, just like Trevor said. I think that this is one of those patients.
Yeah, absolutely agree. Very well said. And I just want to, for the fellows, I think you have to have both those perspectives in the back of your mind. and sort of, think about what's right for which patient and do the best you can. And that's where the tumor board comes into play, right? I mean, because as a surgical, oncologist and a patient coming to you, you want to help everybody, but then your colleagues will help put things into perspective at times. And so that's how you sort of lean on each other to make those decisions.
Yeah, I think the hardest thing we do as surgeons is say surgery is not the right answer, because you can almost always cut something out, but the question is, should you? And so when I think about resectability, I put it into 3 different categories. First, you have the anatomic resectability. So, masseter space here, skull base, et cetera. Then you have what's functionally resectable. And I would argue this almost borders on not being functionally resectable, even if you could get widely around it. And then lastly, I like to teach that there's, you have to ask what is biologically resectable. Is this someone that's had 3 resections already, failed radiation, chemo, et cetera, or are they immunosuppressed organ transplant? Obviously not Caitlin's case, but those are things that I consider when I look at resectability on an individual basis.
I think that's a great point, Cecilia. And then there's probably a 4th one, which is just like the patient themselves. Like this patient, what would a 10-hour surgery do to this patient with dementia? What would it do to their dementia? What would all that treatment do? All the anesthetic, you start worrying about what if they wake up and they're not the same person when they went to sleep. So there's that point of did you help them globally? This is it's a sad case, like you mentioned it would be, but it's a case that I think is great for the fellows to really think about, that it's not easy. And it's not easy to be in that position.
For sure. Thank you, guys. So I did bring it to Tumor Board, and I'm not sure why I can't advance my slides right now. There it goes. And like you all said, recommendation was immunotherapy or hospice. However, I spent a lot of time with them. They spent a lot of time with our radiation medical oncologists. They weren't really quite, especially the wife, they really were not quite ready to accept hospice or immunotherapy as palliative treatment. So the compromise was radiation. Medical oncology didn't think he was fit for any kind of concurrent chemotherapy. Plan is for a hypofractionated course and potentially pivoting to a palliative radiation if he doesn't tolerate that. That's where we're at.
Mm-hmm.
That is a tough case, Caitlin, but very, very real world.
Yeah. And Caitlin, I have to say that, I think the biggest contribution you made to this family is, spending the time to give them all their options. I think that's so important, and I'm sure that they appreciate that very much.
Thank you all for your input on this one.
That was a great case. So we're at 2 minutes from the hour. So first of all, thank you all for somehow being on time. And thank you for 3 great cases that sort of ran the gamut of challenges, right? The challenges of how little to do versus how much to do. So thank you to our 3 panelists, Mia and Jeremiah and Caitlin, and to our 3 experts, Rohan and Cecilia and Steve. Really appreciate you all sharing your guidance tonight. Any thoughts from the chat? I see one message. I mentioned, I think I've caught up to the chat as well. And I think frailty, which was brought up, is something that we don't talk about enough, and really managing frailty. So just to highlight and lift that up, that's a big part. I think what you did really helpful for this patient was give them the strength to kind of have time to make decisions.
Yeah, great session, guys. Thank you all so much. I think that last case was, I think we struggle with those all the time. And some of the bigger challenges are when they and their family are really pushing to have something done, and it's kind of on the border of whether, they're not going to do well. I guess one last question before I know we're about at time is, anyone's thoughts on when to include ethics consults, when somebody's really pushing for something that is inappropriate, but still kind of within the standard of care. I infrequently do it. I usually just try and, to be honest, sometimes set up a 3-way conversation with myself, the patient, family, and the palliative care team, just to kind of weigh definitive treatment versus a more palliative route. And once they get that, both sides of it, they usually are in a pretty good position to make that decision. But curious if other people have other thoughts on that.
I mean, I think like you can't prepare these patients enough, right? I mean, so from an ethical perspective, to have those conversations is so important, and to be mindful of that. I think one of the things that served me well is making sure that I don't make any decisions on the first visit. You know, I try to have them come back in a few weeks, after their, imaging is done, and sort of split the discussion and get more deep into it the next time. And that really sort of helps them process. That's what I'd like to add to what you just said.
Well, thank you guys all so much. I know we're at time. Thanks to everybody for being a part of this, and to the excellent case presenters and discussants. Also, thanks to many other AHNS faculty who called in. Don Weed, I know Jeremy Richmond was here, Arno Bewley, Tony Eskander, and sorry if I'm missing any others, but thank you all for taking the time. This is obviously a really important thing for our fellows. Our next session is on September 6th, Wednesday, complex soft tissue reconstruction of the head and neck. So that's always a crowd pleaser. Excited for that one. So thanks for everybody for calling in. I look forward to seeing you next time.
All right, thank you.
Thank you, everyone.
Thank you.
Thank you.